I want to thank the organizers for allowing me to speak on neonates with congenital heart disease, delivery room resuscitation. My name is John Berger, and I come from the Children's National Hospital in Washington, D.C. We do not have any relevant financial disclosures. The objectives of my talk today are to discuss the importance of carrying a pregnancy to term, to discuss common therapies used in the cardiac resuscitation of a baby with congenital heart disease, and review patient populations that require immediate cardiac intervention. The first consideration in caring for children with congenital heart disease or fetuses with congenital heart disease is planning the timing of delivery. And it is important that these babies deliver at term. We know from many studies that premature birth and low birth weight are very hazardous for infants with congenital heart disease. And that early birth and underweight birth carry substantial mortality and morbidity risks. In this study, looking at patients in the Society of Thoracic Surgeons database from 2002 to 2004, the authors asked the question, is low birth weight associated with increased surgical mortality? In this study of 3,000 patients, 517 weighed less than 2.5 kilos at birth, and the risk of death for those patients had an increased odds ratio of 1.5 to 3 times higher rate of death, or odds of death, if weighing less than 2.5 kilos. The odds varied based on the severity of the congenital heart disease. And the highest odd was actually seen in the lower category, or lower complexity congenital heart disease. But even near term or late preterm birth is associated with increased morbidity and mortality. In another Society of Thoracic Surgeons congenital heart disease database study, there were 4,784 patients who had a cardiac operation at less than 28 days of age. 48% of those patients were born before 39 weeks. And the authors in this study analyzed the data by gestational age between 34 and 40 weeks to see the effect of gestational age on mortality, morbidity, and length of stay. And using 39 weeks as a reference value, the odds ratio for mortality increased to 1.34 if the infants were born as little as 2 weeks earlier, and this was statistically significant. Postoperative length of stay was also longer in children born earlier, as was the number of complications. What sort of complications did these children have? In a single center study, looking at approximately 100 infants or newborns with congenital heart disease, infants who were born at late preterm compared to term were obviously born with less birth weight. They had a longer preoperative hospitalization. They weighed less at the time of their surgery. They were more likely to be require preoperative vasoactive agents. They had a much higher incidence of necrotizing enterocolitis, seizures, feeding disturbance, and they had a much higher mortality rate. The other important consideration about delaying birth to term in children with congenital heart disease is that we know that the brains of babies with congenital heart disease have delayed maturation. In an MRI study looking at white matter maturation index, the study showed that infants with congenital heart disease born between 37 and 41 weeks had brain maturation, white matter maturation equivalent to an infant born between 36 and 37 weeks in patients with hypoplastic left heart syndrome or detransposition of the great vessels. And we know that immature brains are more vulnerable to both ischemic and hemorrhagic injury, and periventricular leukomalacia is seen in children with congenital heart disease, similar patterns to those who are born prematurely. So maintaining a pregnancy until delivery is one of the key takeaways from this talk. Well, let's talk about delivery planning. What are the variables to consider when planning for a baby with cardiac disease? Well, the primary variable to consider is the risk of hemodynamic instability at birth or in the delivery room. However, you also have to take into consideration the resources of the region. That means both technical resources, for example, the availability of ECMO or catheter-based interventions at a cardiac center, as well as the personnel, cardiac intensivists, the availability of cardiologists, cardiac surgeons, and transport teams. There has to be a consideration for obstetric complications, obviously vaginal versus cesarean delivery carries important morbidity differences for the mother. We've discussed the timing and well as mode of delivery. So the first thing to understand about caring for newborns with congenital heart disease is that routine resuscitation in the infants with congenital heart disease is usually all that required. Most congenital heart disease is well tolerated in utero. The placenta is an excellent substitute for extracorporeal oxygenation or ECMO. Rarely are specialized treatments required. And if intervention is required, it is usually the normal newborn ABCs, airway, breathing, and circulation paradigms. But when needed, cardiac care is highly specialized and means thinking about zebras and not horses or camels. So the real challenge for the cardiac center is to identify the ultra high risk patient and provide consultation and strategies to the delivery hospitals about caring for these infants. As I said, most of the time, infants with congenital heart disease do not require resuscitation, and if they do, it's nothing more than normal ABCs. In a study looking at 110 infants with congenital heart disease who had a neonatologist at delivery, only 10% required additional resuscitation beyond the normal newborn stimulation and care. And this is actually no different than infants without congenital heart disease. Well, working at an advanced cardiac center as I do, we have developed for our center a stratification system based on the risk of instability at birth. And this risk stratification system extends from a level 1 to a level 4, level 4 being the most high-risk group of infants. Patients who are deemed to be without risk of instability in the delivery room are so-called level 1 patients. Examples of that are ventricular septal defect, complete atrial ventricular canal defect, and mild tetralogy, all infants who should look relatively and act relatively normal at birth. Patients in this risk category are delivered at their local hospital with routine obstetrical care and routine delivery room care. And these babies can be evaluated as outpatient with a neonatal cardiology consult. Level 2 infants are those that have minimal risk of having instability in the operating room. And these often include ductal-dependent lesions such as severe coarctation of the aorta, interrupted aortic arch, and severe tetralogy of Fallot. Consideration is often given to having these planned induction for these children so that transport to the cardiac center can occur in a timely fashion. A neonatologist is often in the delivery room, and PGE or prostaglandin E is started as indicated. And the patients are semi-electively transported to the cardiac center for surgery and intervention. Level 3 infants, on the other hand, are those infants who are likely to need immediate delivery room stabilization. Often these are the babies where we're not quite sure whether they're going to be sick in the delivery room or not, or those infants where routine initial care will stabilize the baby. In these infants, we usually recommend planned induction. Occasionally, we'll recommend a cesarean section type of delivery if there's a need to coordinate the care between the cardiac center and the delivery hospital. There will be a neonatologist in the delivery room. We will often send a specialist from the cardiac center, either a cardiologist with an interest in delivery room management or a cardiac intensivist to the delivery room to assist in the resuscitation. There is a planned rapid transport to the cardiac center with an aim of being in the cardiac center within a half an hour of delivery. And typical types of heart disease that require this kind of care are infants with detransposition of the great vessels, infants with uncontrolled arrhythmias, and those infants with heart failure secondary to congenital heart block. Level 4 types of infants are generally children who have obstructed pulmonary venous return. And there's sort of 3 prototypical types of congenital heart disease. There are those infants who have detransposition of the great vessels, or DTGA, with an intact ventricular septum and a restrictive atrial septum. There are infants who have hypoplastic left heart syndrome and an intact atrial septum. And in both of these lesions, the children quickly develop lung congestion and pulmonary edema, and so develop a profound acidosis, both respiratory and metabolic, as well as profound cyanosis. Similarly, those infants who have total anomalous pulmonary venous return or with obstruction will also have this same combined pattern of cardiorespiratory failure, and will quickly all proceed to cardiogenic shock and extreme hypoxemia. So the 3 physiologic groups, the first are those babies with pulmonary venous obstruction who develop stenosis and respiratory failure. There are babies who have in utero heart failure and hydrops, either from arrhythmia, Epstein's anomaly, or complete heart block and cardiomyopathy. And then finally, those babies who will have severe airway obstruction and/or pulmonary hypoplasia as a result of their congenital heart disease. In our center, level 4, or those infants requiring immediate care, are delivered at the cardiac facility. In our center, that is one of the cardiac operating rooms. This allows for immediate access to cardiac catheterization, balloon atrial septostomy, or other methodologies to open up the atrial septum, as well as the ability to put the patient onto ECMO either before delivery or right afterwards. These deliveries are often planned cesarean sections to coordinate the cardiac care between the different teams. And our teams are always prepared, but not always needed in this situation. Some of the keys to success if you're going to embark on caring for these highest risk infants, you do need to have a full set of treatment options. You never know exactly what you're going to need until after the baby's born. That includes typical things that we see in the CICU, vasoactive agents, nitric oxide, catheter-based techniques to open up the atrial septum, as well as the availability of ECMO. Another very, very important consideration is the realization that you are activating and bringing together multiple teams, all with sub-team leaders, so that you have a maternal team that is focused on delivering the baby and the mother's well-being. You have the delivery team who's focused on resuscitating the baby, a transport team, an ICU team, which is often involved in decision-making regarding ECMO use, a cath team, a diagnostic team, as well as anesthesia and surgical teams for placing patients on ECMO. And obviously this requires clear communication and frequent practicing of the delivery in high-fidelity simulations. When we carry out one of these level 4 deliveries, we have very well thought out process maps that tell us where and what's going to happen in each phase of the delivery, as well as maps to show where all the different players are to stand during each phase of the delivery. And in our institution, in one of these deliveries, it's often upwards of 20 or more people who are involved in the delivery of the infant. We did a review of our deliveries, both of level 3 and level 4 infants, carried out in our institution between 2005 and 2012. In that time period, we had 15 level 3 deliveries and 19 level 4 babies born. Only 12 out of those 19 infants, however, were born as planned at Children's National Hospital. Of the babies delivered, in the level 3 group, approximately half, or 8, required immediate cardiac intervention. 8 out of 8 had a balloon atrial septostomy. 1 of the 8 required ECMO. And the mean time, or the median time to intervention, was almost 2 hours in that group. With a level 4 type planning, 16 or 84% of the 19 infants required immediate intervention. 13 of those interventions were septostomy, 2 were ECMO. And the median time to intervention was cut approximately in half using a level 4 strategy versus a level 3. And all of these infants survived and had their operations for congenital heart disease as planned. So what constitutes routine cardiac care in the delivery room? What do you need as a neonatologist to be prepared for? Well, the 2 most common questions that I get as the cardiac specialist from the neonatologist is, should I start prostaglandin E1 and should I give the baby oxygen? So to answer the first question, if you're in doubt, start it. There are relatively few downsides and relatively few side effects to starting prostaglandins. However, starting prostaglandins in the delivery room is not an emergency. The ductus is open and usually will remain open in the delivery room. In an cardiographic study looking at ductal closure in normal term infants, only 8% of the ductuses were closed on the day of delivery echocardiogram. It wasn't until days 2 to 4 that ductal closure was fully achieved. And so you have some time to get an IV placed and the prostaglandins shot. Whether you should give the baby oxygen or not depends on what the saturation goal is, and the cardiac center should be providing you a saturation goal in the initial, as part of their initial consultation with you. Some of the things that you should learn from your cardiac center about each of the babies with a prenatal diagnosis. You want to know whether there's one or two ventricles and what the heart function is. But more importantly, you want to know how blood flow is going to get to the body, how blood flow is going to get to lung, because that's going to determine whether you need to have prostaglandins available and whether you need to keep the ductus open. You also want to know whether there's any risk of obstruction in the blood returning from the lungs, because if there is pulmonary venous obstruction, either at the vein level or the atrial level, that infant can quickly develop pulmonary edema and respiratory failure. And will the respirations be? So using prostaglandins, the original dose, if you read the literature, is 0.1 mics per kilo per minute. That is usually not necessary in the delivery room. But you can get equal efficacy at a much lower dose and then therefore have less side effects. In most cardiac centers, doses greater than 0.02 mics per kilo per minute are only rarely used. And if used, you have much higher likelihood of the infant developing apnea and requiring intubation. Additionally, higher doses are associated with necrotizing enterocolitis and the need for mechanical ventilation. And the 0.1 mic per kilo per minute dose is really a dose that I only use when it's necessary to open the ductus arteriosus after it is closed at several days of age. What about oxygenation in the single ventricle patient? What's the oxygen saturation goal? This is a very common question. And these are patients, to break it down into simple physiology, these are patients who have both systemic and pulmonary venous return, returning to a single pumping chamber with a single outflow, and that admixed blood is then partitioned between the body and returning to the lungs. And if you send too much blood to the lungs, you're going to have too little blood flow to the body. And so the real goal here is oxygen delivery, not oxygen saturation or oxygen content. And so if you plot oxygen delivery based on arterial saturation in patients with single ventricle anatomy, there is a sweet spot or an ideal saturation somewhere between 75 and 85%, which will maximize oxygen delivery to the body. If your saturations are too high, you are sending excessive blood to the lungs in order to get the saturation that high, and potentially reducing the amount of blood flow to the body and therefore have inadequate oxygen delivery. Clearly, if the patients are very cyanotic, there's not enough oxygen content, and the babies are equally compromised. What is the specialized care that I can provide and my team can provide? There are basically two things in the delivery room or shortly after delivery is either ECMO, again, either before delivery in an exit type procedure or shortly afterwards, and atrial decompression using a variety of if we look at how the importance of these interventions, for example, looking at atrial septostomy, in patients who have DTGA or detransposition of the great vessel and a restrictive atrial septum, in a study looking at 295 infants with this issue, 12 of the 295 infants died before surgery. All of these infants had profound hypoxemia from a restrictive atrial septum. None were prenatally diagnosed. 2 out of 11 responded, only 2 out of 11 responded to PGE with a small rise in arterial saturation. 8 patients out of the 12 had a balloon atrial septostomy. However, the time to septostomy was 17.5 hours. And again, this is very long in patients who have such profound hypoxemia and acidosis. And 4 died before they could get to balloon atrial septostomy. So again, patients with DTGA, you're going to want to have a plan to deliver them close to the cardiac center, if not in the cardiac center, to get them to intervention to prevent early death. The same can be said for patients with hypoplastic left heart syndrome and atrial restriction. However, the results are less robust given the severity of the overall severity of the congenital heart disease. The survival of these infants in this series was only 50%, but 50% compared to 0 if you do not do an atrial intervention. So in conclusion, I hope that I have given you the tools to understand that the key anatomy in understanding the physiology of babies in the delivery room, or whether the baby has 1 or 2 ventricles, how the blood gets to the body, how the blood gets to the lungs, and importantly, how the blood gets from the lungs back to the heart. Oxygen is neither good nor bad, but knowing the correct oxygen saturation goal is important. For those caring for the highest risk babies, you need to have a full complement of therapy options, including ECMO. And most importantly, your team needs to prepare and actually practice caring for these very complex and fragile babies. And again, I want to thank the organizers for the opportunity to speak today.